So that's what I want to get into specifically on the issue of doctor-prescribed suicide today, because this is the most pressing issue that we're facing in terms of being on defense in the state of Maryland this year. The other side is marked Maryland as one of their key states that they want this to become law. We will be the 5th state in the country to do that if they end up succeeding in this. So I'm going to go over very quickly, and I have all the points also in your printouts of this, key talking points on this issue. So that way you can take them to your legislature, you can take them to other people that can cite evidence as to why this is a concerning policy. So first I want to talk briefly about what this debate isn't. When we talk about doctor-prescribed suicide, we're not talking about whether or not one has a choice to stop, withdraw, or refuse a given treatment. That's already Maryland state law. Anyone can choose not to have a given treatment. Doctor-prescribed suicide is something very different. This debate isn't about administering medication which could but is not intended to hasten death. That's already protected in Maryland law. The reason, perfect example of that is morphine. You have somebody who has cancer, giving them morphine will slow breathing and reduce the heart rate. It could have an unintentional effect for someone, particularly at the very end of life, to hasten death. But the intent of giving morphine is not to overdose them on morphine or stop their heart. The intent is to control pain. And it's not merely a question of elderly health care. It is this, but it affects all of us regardless of our age. Some of the strongest opponents to this legislation are from the disability community. Because they look at this and they say, look, we're already on the chopping block, so to say. We have to fight for every ounce of health care we get because there's a bias, there's ableism that assumes that I don't have the same quality of life as somebody who can walk, or somebody who can do this or that, or what have you. So this is going to be immediately pressured on me to end my life early, because realistically, my health care costs a lot more than somebody who doesn't have medical issues. And these are the concerns that are raised. So we want to take a reasoned approach. We don't have to theorize about the impact of doctor-prescribed suicide in Maryland. We really have the analytical benefit of other states legalizing this before us. And I say before us, it's just a matter of time, because this is a winnable fight. We do not have to lose this at all. We have the benefit, particularly from Oregon, a state which enacted the law over 18 years ago, very similar to the proposals in Maryland. So we can look at those same safeguards, because in the end, the question in everyone's mind is, will the safeguards work? That's what's on the mind of every single legislator. There are certainly some that are dead in the wool against it, just as it is. God bless them. There are some who, very few, that just want it regardless of what happens, but nearly everyone is concerned, do the safeguards actually work? So let's take a look at them, because we have the benefit of looking at Oregon. Did they work there? So who is eligible? What is a terminal illness? In each of these sections, and I'm not going to read every bit of it because you have it on your handouts and we just don't have time today. This is proposed language directly from the drafts that came out on Friday of the legislation before us this session. They define a terminal illness as someone who's likely to, a prognosis for an individual that's likely to result in death within 6 months, to the best medical judgment, a reasonable medical judgment of a physician. Reality on this, there's a problem. Treatment's not considered the determination of estimated lifespan. This means, as shown in Oregon data, patients with diabetes, HIV, and hepatitis and other such conditions are legally given prescriptions to end their life. Diabetes. Think about that. If you're an insulin-reliant diabetic and you can be considered terminally ill if you would choose to cease taking any insulin and treatment ever. Normally, in the United States, that would not be considered a terminal illness. But because you don't have to factor into potential treatment, a lot of things get grouped into terminal, which we normally would not be consider a terminal illness plaguing society. We have the reality that lifespan is also not easy to predict. This isn't criticize physicians and a failure on that end. I'm sure they do the best that they can, but the reality is this is an estimate. And we have untold numbers of stories where some that they're very accurate and they're dead on. And we're thankful for their medical expertise here. But medicine is also very difficult to predict. Cancer by its very nature, biologically, is difficult to predict. So unfortunately, we have cases where your 6 months time frame, 5 years later, we're still waiting for that to be on your deathbed here. That's not terminal at that point. And how many people get wrapped in believing that they are and make a decision they wouldn't otherwise would have. That's very important. Either way, time shared with loved ones at the end of life is often a healing, a powerful emotional and spiritual experience to be able to share that time. And I'm sure other people who've had that opportunity to be with a loved one at the end of life can probably testify to that reality, especially if they were able to get good, quality, dignified health care, perhaps hospital at the end of life. Patient control of drugs. In short, it's given just as any other drug through a pharmacy, through the doctor, directly to a healthcare agent. But the difference that we have here, in Oregon, data show that patients have held on to these drugs without taking it for as long as almost 3 years. Not only does that obviously call into question, what happened to that terminal diagnosis again? A little bit off. But we also have the reality that we have a prescription bottle of drugs that's solely intended to cause death out there. And it never has to be turned into anyone if you don't choose to use it again. What happened over that 3-year period of time, almost 3-year period of time? Did the mental state deteriorate? Is the person no longer able to self-administer? Did caregivers tire of caring for the patient? What happened that changed over the course of that time? That's a tremendous long period of time without any review. Not to mention we have a bottle of drugs intended to cause death with a opioid and other drug epidemic facing the state of Maryland. And we're going to have barbiturates that are solely intended to cause death if taken in large quantities, and can certainly be taken less if you're in a more frail state, someone who's already heavily addicted to a particular substance, or a child. How is this going to be circulated out there? Is this ever going to be turned in? The bill doesn't require that. Witnesses and heirs. The bill is phrased right now that where only one of the witnesses to one's request for doctor-prescribed suicide can be entitled to any financial benefit from the death. First of all, that never occurs in any other contract law where any witness can be of financial benefit for them going through with that. That's never the case. Why is one of two allowed is beyond comprehension. And here's the thing. If we have an issue of undue influence or coercion that got someone to request this when they wouldn't otherwise, don't you think they have enough influence to be put into the will after the fact? Nothing stops them from being a financial benefit after the request. You can have both people benefiting from this, and as long as they're able to do it privately enough and not get caught, there goes the patient and they're entitled to benefits. There's obviously issues for abuse here, not to mention endless lengths of litigation from other family members on this issue. Absolutely nothing serves to meaningfully protect patients from this type of undue influence and coercion, medical abuse from caregivers, so on and so forth, which unfortunately are very much realities in the state of Maryland. We have bills and other hearings on these particular issues, yet we're considering something like this that would only exacerbate these issues. The doctor-patient relationship, as we mentioned before in the action alert, the shortest time frame for a doctor-patient relationship before getting drugs was 0 weeks, as put in their report. Now certainly there are others that have long-standing relationships with their physician when they request a lethal prescription. Sure, that happens. But the very fact that we have anything that's 0 weeks indicates that there was clearly doctor shopping involved. And we have plenty of examples of this in Vermont and in Oregon already, where we have an issue of someone requested it, the attending physician said, no, I've treated you for 10 years. It's very clearly you're even diagnosed with depression. I'm not going to give you a prescription to end your life. We need treatment for the underlying condition, and then let's reevaluate what treatment to give you for your cancer. That's a fair point for a medical person to make. What's not fair is when they come back, they call compassionate choice and get referred to a physician who will sign that request and allow them to get that immediately. Not even giving them a mental health evaluation when they're diagnosed with depression. Notably, in the work group on the doctor-prescribed suicide, there was a person from Oregon that testified who's part of the procedure that, and very familiar with the regulations around doctor-prescribed suicide in that state. She said, quote, depression does not eliminate someone's potential from getting a lethal prescription. Depression is not an eliminating factor. You can be depressed, request a lethal prescription, and that's considered okay. Normally, that's not how we treat depression. And that shouldn't be how we treat depression. For Maryland being such a leader in mental health, the last thing we would want to do is somebody with a mental health issue which could clearly cloud one's ability to make a judgment that they would otherwise make if in a proper state of mind receiving proper treatment, and give them the opportunity to end their life, confirming their worst fear of being unimportant and useless and a burden. That's the worst thing that we possibly can do. And this is a serious problem.
Bribes going to doctors?
What was that?
Any records of bribes going to doctors to purchase medicine?
I don't have bribes per se, but there's enough people who are willing to write it ideologically regardless of the underlying conditions of the patient. So a bribe, unfortunately, is not necessary. Mental health evaluation. In Maryland, there is no requirement that someone requesting a suicide cocktail is given a mental health evaluation. It is only if the attending physician or consulting physician believes that there's a reason clouding their judgment. And again, we've already said that depression does not qualify as that apparently. We have the reality of an Oregon. The Oregonian has reported that patients with diagnosed depression and diagnosed dementia have received lethal prescriptions to end their life. I'm running out of other examples to give of reasons that clearly this is no longer a person in their proper state of mind getting a lethal prescription. This is allowed and legal in Oregon, and nothing in Maryland's proposed language is any different to stop that from happening right here. That's not a good situation, and that alone should be a reason not to pass this bill. When is at the time of death? Proposed language is very nice. The physician has to counsel the qualified individual concerning the importance of having another individual present when the patient takes the medication and not taking it in a public place. And they should also consider participating in hospice. Well, that's great. There's nothing prohibiting someone from going to a public park and taking the drugs and dying in a public park. There's nothing mandating a patient has to tell anyone else, largely because we have HIPAA protections. As I mentioned, you don't have to share your healthcare information with anyone else if you so desire. But here's the reality is, we have no one that's monitoring what happens after they get the prescription. We've already seen from Oregon extending nearly the length of 3 years before death occurs. We have death occurring apart from that, so we have prescriptions out there. We have no idea what happens in that time frame. We already have evidence coming, I believe that is out of Oregon, the issue of Kate Cheney and her story, where after she received the prescription, her family decided, we're going to take a vacation for a week and put you in a home temporarily, because we just need a break from caregiving. When she got back from the week, she wanted to take the drugs. Well, did she want to take the drugs because she wanted to take the drugs, or did she want to take the drugs because she realized her family didn't care about it? One of the top reasons that people in Oregon have cited for requesting and taking this prescription, this lethal prescription, is feeling like a burden on family and friends and caregivers. That's one of the top reasons. That should break our hearts as a society, that you want to end your life because you feel like you're a burden. But instead, what this law allows, what this bill would allow, is to fulfill your worst fears of actually being a burden and helping you get out of the picture. That's not a compassionate way to treat people in the state of Maryland or anywhere else for that matter. They say that the state can punish violations, but that's really not the case. What we see in Maryland, and different states have a little bit different language in this, but in Maryland, what we see is that the physicians are held to a good faith compliance standard. Now, this doesn't mean a lot for people outside of the legal framework, but a good faith compliance standard is a far lower bar to reach than the standard malpractice compliance standard that most medical professionals are held to when, performing medical treatment and care. This is a concern because this is not just something where I thought this was the right thing to do and I did what's generally, I should do, and I made an honest effort at being right. Versus, you have a malpractice standard, and if you screw up and you're doing something apart from what would be an established ethical standard in your community, you're held legally liable. This is a matter of life and death. This is not removing a wart in a dermatologist's office. This is a matter of, we're literally determining how someone lives and dies. Why would we want to hold someone to a standard that's less than what it could be when we're talking about literally life and death? That's ridiculous. That's incredible that we have the lethal prescription going out there. First of all, if family knows about this, then you have the option if anybody else wants to end their life. They have the means to right there. Not only do we have the suicide epidemic, but we have several studies showing that there's a suicide contagion effect where they legalize this. That is, that we don't have the suicide rate even plateauing or decreasing when we legalize this. The suicide rate generally, apart from doctor-prescribed suicide. So it isn't people who otherwise would have ended their lives that are now going through this, legal sanctioned way to do it. But rather the rate either stays the same, meaning more people actually ended their lives, or it goes up because we redefined our sense of autonomy and what's the right approach to suffering. And that is extremely concerning in light of a broader suicide epidemic that we have not only among teens, that we have among veterans, that we have among LGBTQ community. Every community that has a higher suicide rate than average should be appalled that this could ever have the effect of saying that, yeah, there are reasons why you just shouldn't be allowed, or shouldn't really be self-administered. This is one of those very issues. The Oregon Attorney General, when they were debating the passage, said that this law requiring a self-administration, that means the person has to take the pills themselves, is actually unconstitutional via the 14th Amendment under Equal Protection Clause, as well as the U.S. Americans with Disabilities Act. Because you are establishing a legal right entitled to some people with certain abilities that you would not allow someone who does not have the ability and disability to swallow or use their arms. Meaning, this is one court challenge away from being outright euthanasia by lethal injection or another means. And here comes that slippery slope approach, which is the reality. Because are we really going to say, in a court of law, is this really going to be upheld? Or is this going to be found unconstitutionally discriminatory? That's what the own Attorney General in the state of Oregon at the time this passed said. So this is the problem we have. We can't control it, even once it does. We already have lots of other areas of abuse that we can't control. But this, just by passing any form of this opens it up to a court challenge. This is not what legislators really, I believe, want to do. So is this really what we're going to do? Because this is really what we're voting on. It's just one court challenge away, and then the legislature gets no say over what happens. The request must be voluntary, is another safeguard that proponents say. Really nothing, as we mentioned before, would stop pressure from caregivers, heirs, family, or anyone else. Oregon's own reporting shows top reasons of feeling a burden on family and friends, as we mentioned before. That's extremely concerning. But there's a feasible alternative requirement in Maryland's law which says that when getting the prescription and requesting it, the physician has to say, look, there are other feasible alternatives like hospice and palliative care and so forth. Well, great. That's absolutely great. Unfortunately, the feasible alternatives aren't necessarily feasible for everybody. There's no requirement that insurance cover those. So this is the very issue that we've seen in Oregon that are going to happen here, is that now we've created two separate standards of health care for those who have resources and those who are in poverty. And if you don't have an insurance plan quality enough that covers this in full, then your feasible alternative costs you tens of thousands of dollars a year, or you can pay a few $100s, maybe $1,000 at most, for this. Well, what becomes more feasible at that point? That's like saying anyone here has the right to live in a mansion in Hawaii, on the beach. It just costs you $10 trillion. That's your feasible alternative. Well, it's not actually feasible now. None of us has $10 trillion, and if you do, we need to talk afterwards. and what we have here, and there are lots of stories. These two stories have been used quite a bit. There's a lot more on Maryland Right to Life's website, among others. But the stories of Barbara Wagner and Randy Stewart. And this is exactly why near legalization is going to be a threat to legalized health care for everyone in society. They were both diagnosed with cancer in the state of Oregon. Their doctors told them that, hey, in light of the fact that you're choosing that you want to treat this at this stage, because everyone has a right to reject health care, remember that. They said, no, we want to fight it. We're at a point, we want to fight the cancer. We want a chance to try to beat this. It's like, okay. Doctor gave them, here are some drugs that you could try that I think would be more tailored to what you're going through, that would be appropriate for your health situation, that will give you the best chance of beating this cancer and surviving. This is my medical opinion. Okay. They were both on the Oregon Health Plan, which is Oregon's Medicaid system. So right off the bat, there are people in poverty. They wrote a letter requesting that the Oregon Medicaid program cover it. They received a letter denying that request. That's bad enough, but they were nice enough in that letter to remind them of their option for doctor-prescribed suicide. And here's the concern that we have. First of all, Oregon no longer sends letters to people because they realize this is very, very, very bad press They now make phone calls with that information. Not a job that I think I would want to apply to. But nonetheless, what we have is a situation that this really highlights, and that's the mere legalization of doctor-prescribed suicide gives you a cheaper option than treating any underlying condition. There is nothing that can be anywhere close to terminal or even a severe diagnosis. Even something dramatically impacting our quality of life that wouldn't necessarily be considered terminal, like diabetes. Nothing is going to be cheaper than one bottle of 100 pills to end your life. Nothing. And if a state plan can do this, a government-run program of Medicaid, if this goes enough and this becomes a countrywide policy, nothing stops Medicare from doing it. Nothing stops Medicare from doing it in individual states where that's legal. And nothing stops private insurance plans. Nothing stops anything from the healthcare exchange from doing this as well, if it were a legal policy. Because insurance companies have just the same profit motivation as any other business. And what's more profitable? Tens of thousands, if not hundreds of thousands of dollars in cancer treatment and chemotherapy and radiation and surgery and your counteracting pills in order to anti-nausea. You got to have something much more powerful than Zofran to do that. Your hair loss medication did not work for me. But you have all these different things now that you have to cover in order for this. Hospice care is a lot more expensive than a few $100s of pills. Because you're getting high powerful narcotics and opioids in order to control pain. Not to mention hiring a staff person. You're either in a hospital or you're in home care hospice in the state of Maryland. Either way, you're paying someone to come out and do some care, at least occasionally. There is nothing that's going to be cheaper than this. So that's our concern. The mere legalization allows any insurance company, nothing in the law prohibits it, from saying, no, we're not going to cover your life-saving care. They can make any type of discriminatory policy as far as when they're going to implement that. But nothing stops them from saying, no, but we will cover your suicide. So you can either die like this, or you can die according to the way we're going to pay for it. Your call. That's not a feasible alternative. That's forcing someone into death when they didn't otherwise have to be. And that's why we oppose this policy on its very merits. The mere legalization, no matter how much they choose to clean up in this, which again, is not something that the other side is willing to clean up. That's why we bring it up, in order to educate people about it. But the mere legalization, if for some reason they would, is still innately threatening to everyone's access to health care in the state of Maryland.
Jeff, I would add too on that point of voluntary that this flimsy safeguard of the, that the person requests it of their own volition and everything, all those safeguards end immediately as soon as the prescription's written. There is no protection once that person has that prescription in their hand. So no one knows whether they took it of their own free will or not once that prescription's in their possession.
And we have
There's no oversight after the fact.
We have evidence from, I believe it was Vermont, it could have been Oregon, forgive me if I got the straight wrong, but that very case, where someone started, they no longer had use of their arms, it could have been an ALS or another issue, but had the pills already, and told her grandsons to crush them up in applesauce and feed them to her.
Oh.
Exactly. There it is, and there was, otherwise than them admitting it publicly, there was nothing that caught that to prevent that. And that's exactly against what the supposed safeguard is. The safeguards don't hold any water. And this is why this is extremely concerning. We need to be opposed to it. So in light of all of this, we must voice rational evidence-based reasons for opposing doctor-prescribed suicide to our state elected officials. Because everyone here can look at evidence and can make a reasonable conclusion. All we ask, look at the evidence and make a reasonable conclusion. Do you think it's reasonable in light of all of these challenges and how it's going to affect people in poverty, minorities, how it's going to affect people with mental health issues, how it's going to affect the elderly, and how it's going to affect people who don't have another option and are too poor to be able to afford their own health care and tens of thousands of dollars out of pocket, to tell them that they can't have life-saving care? But I'm guessing that among all of those people, you're not going to want to irritate if you even have an ethical bone in your body and don't want to do that to other human beings. And this is the case that can be made. And this is the case that anyone in the legislature can understand and can accept. So I encourage you, please spread the word, define the issue for what it is. It's not compassion, not at all. The first inclination people have is compassion. That's why polls show large amounts in favor of it, 65% or so of the country in favor of it. Because the first inclination is, do you want to be compassionate at the end of life? Well, sure, I want people to die what they're going to do. I don't want people to die like this. And the very same thing happened in Massachusetts, where 60-some% of the population said that they were in favor of it when it was passed. They were in favor of it in September. By the time November came around for them to vote when it was petitioned to referendum, 52% voted it down because they started hearing these issues. And they said, no, this isn't actually dignity. Dignity was what we had with hospice. Dignity is expanding access to health care and these options. Dignity is not doing something which can limit access to
What
that.
was the reaction